Hey everyone, welcome back to my channel. So in this video, I'll show you how to approach a CCS case about vaginal bleeding. First off, you need to decide the location where you're going to manage the patient, but that only happens after you do a physical exam, because when you do a physical exam to determine the cause, you also want to determine the patient's general condition, whether this patient is unstable or not, also based on their vitals and how much she's bleeding, if she's changing her pad or tampon every hour, she's passing blood clots. Obviously, you need to admit this patient in order to stabilize her and also find out the cause extensively. In that case, you're going to change the location from office or ER to inpatient unit. And that's very important, guys. You lose points if you treat the patient in the wrong location. So first off, we're going to do a physical exam. General appearance shows you whether the patient is pale, distressed, and her overall mental state. For example, abdomen and genitalia and rectal are the three most important systems you need to examine for a patient coming in with vaginal bleeding, because it would show you if the patient is pregnant or not. It would show you if there's any ovarian or uterine lesion or cervical lesion, and if the bleeding is actually from the vagina or from somewhere else. A rectal exam will also determine if there's fibroids or adenomyosis that could be causing it, like structural causes. Now, moving on to the diagnostics. The number one thing you need to do in a woman of childbearing age is a pregnancy test. So this should be on top of your list, a beta HCG. A urinalysis, in case this is actually hematuria and not vaginal bleeding, the patient wouldn't know probably. So you also need to rule out UTI as a possible cause. So pregnancy and its complications could be obstetric, right? Could be urologic, so you want to do a urinalysis, and it could be gynecologic, and that is a lot. You got a lot of causes of abnormal uterine bleeding that's gynecologic, whether hormonal or structural. And so for structural causes, the best option is to do an ultrasound. All right. Here you can see polyps, fibroids, adenomyosis. Maybe she has an IUD in place that's causing her that. Maybe a thickened endometrium, right? So structural causes are going to be ruled out with a pelvic abdominal ultrasound. Now about the hormonal causes. Now there's so many hormonal disturbances that can lead to heavy menstrual bleeding or even intermenstrual bleeding, such as hypothyroidism or anovulation, right? So here you want to do a hormonal profile for ovulatory disorders. So you're going to do a TSH, thyroid issues, FSH, and prolactin. Okay, and now to the systemic causes, which can cause bleeding anywhere in the body, including the uterus, and that would be coagulation disorders. This way, we're looking for the cause, extensively looking for the cause. Now, diagnostics do not just involve looking for the cause. You also want to see the effect of this disorder or what is going on in this patient, how it affected her general condition. And so it could cause anemia, right? Could cause orthostasis, orthostatic hypotension, because of hypovolemia. So the number one thing on your physical exam after finishing the physical exam and vitals is to do postural vitals, postural blood pressure and heart rate. The patient could be dizzy on standing up, a complete blood count to check for anemia since she's bleeding, and also possible infection from leukocyte count. A pulse ox is needed for any patient with shortness of breath, and a basic metabolic profile is needed in almost every patient coming in. So this way we've finished the patient's location and diagnostics. Now to the treatment part. The treatment part involves therapeutic treatment, and preventive management. We're going to start with therapy. Since this patient has acute severe bleeding that's affecting her vitals and affecting her general condition, the best option for her at the moment would be a high dose of estrogen, preferably high dose of pure estrogen. It's usually given IV, called equine estrogen or esterified estrogen. You could do that, or you could also give a combined estrogen progesterone therapy that would stop the bleeding, and those are more effective than the tranexamic acids or aminocaproic acid or all those antifibrinolytic drugs. Now, for prevention, if you don't find any of these causes as a possible cause of her bleeding, if all those are ruled out, all those tests are negative, then it's most likely anovulatory bleeding. And that's probably the most common cause. Now, that would be anovulation. That means that she's not producing enough progesterone, and so estrogen is left unopposed to act on the endometrial lining and cause it to grow uncontrollably and bleed. And so that really doesn't have a specific treatment, except that you can probably give her OCPs to like OCPs are combined estrogens and progesterone. So because it has a high progesterone component, it would stop this unopposed stimulation of the endometrium. And just reassure her that this bleeding is nothing and that the cause is not really dangerous or anything, because a lot of patients would be scared, and you would take points for that, in addition to the usual preventive treatment that we know about. Let's say she only received her childhood vaccines, so you want to give her a Tdap booster. Let's say she's smoking, so you're going to advise her to quit, or alcohol or illicit drugs. So those are the usual parts you want to address in prevention, in addition to the actual condition she has. I hope this helped, guys. Let me know what you think.